Good evening, and thank you all for joining us this evening for the Davis Area League of Women Voters Healthcare Forum. My name is Michelle Famula. I chair our local league healthcare committee, and I will serve as the moderator for this evening's forum. The Davis Area League of Women Voters is proud to sponsor this evening's forum with the support of our Davis Area Voter Education Funds and our league membership. We'd also like to express our appreciation for a contribution received from Healthcare for All and local area residents in support of continuing healthcare voter education forums. The State and National League of Women Voters recognize the critically important role of health and wellness in the lives of our residents and the success of our communities. We're assembled this evening using a virtual public forum format because these are especially unique times for our community in both healthcare and public health. To further acknowledge these challenging times, we're asking all to view the healthcare discussion this evening from the perspective, what has the COVID crisis unveiled about healthcare access and affordability in Yolo County? Understanding local healthcare in a time of COVID-19. For more than 40 years, the United States has been looking to legislative and executive leaders to help individuals secure their own healthcare resources. And for more than a century, we've relied on their wisdom to help communities plan for public health and safety. In the coming months and years, voters will be electing the officials who will be addressing the continuing resource and affordability barriers to universal access to care. Tonight, we welcome a distinguished panel of speakers to share their unique and diverse perspectives on healthcare. Through their expertise and experience, we ask that they shed some light on how our national health system plays out in the care received in our own community. The information shared may help us to better understand how our national and local healthcare priorities direct the resources and policies that impact local Davis area care, delivery, access, and affordability. As a program note, I regret to say that Sandra Seacrest, our panelist who would be advising on mental health resources, has been unable to join us this evening, and therefore we will welcome our panel members to include information relative to mental health for the clients they serve. We're going to begin our 2-hour program with our keynote, Dr. James Kahn, Professor Emeritus, Department of Epidemiology and Biostatistics at the UCSF Philip R. Lee Institute for Health Policy Studies. Following Dr. Kahn, our panel of local healthcare providers and advocates will offer their perspectives on care in our community and bring the implications of our current epidemic response into local focus. Finally, we will give our presenters an opportunity to answer questions from the audience that may help us better understand what healthcare strategies our community leaders and our national officials must pursue if we are to successfully assure the future health and well-being of all in our nation. I encourage the audience to use our question and answer function on our Zoom screen in order to submit questions that will be answered at the end of our program. Program hosts will collect these questions for response tonight, and any answers not given this evening will be available online to read. It is now my great pleasure to introduce Dr. James Kahn. Dr. Kahn is the founder and director of the UCSF Global Health Economics Consortium. He is an expert in effectiveness analysis, decision analysis, systematic review, and health costing. He has researched and published extensively on healthcare reform economic issues. Dr. Kahn joins us to present what COVID-19 has revealed about the weaknesses of our healthcare system and the advantages of embracing serious health reform. Welcome, Dr. Kahn.
Thank you, Michelle, and thank you very much for inviting me to participate in this event today. I'm going to start by sharing my screen, which worked brilliantly in the test period. So let's hope that the test was indicative of what we can expect. So someone tell me when you can see my screen.
We can see the screen.
Fabulous. You can see the screen. I'll assume that means everyone can see the screen. As Michelle mentioned, I'm going to talk about how COVID-19 revealed weaknesses in our system and the advantages of serious reform. I'm going to break this talk into three parts: what was going on pre-COVID, what we saw with COVID, and then the approach to reform. This is the percent of US adults without health insurance from 2008 to 2018. We can see starting at about 14.6%, rising steadily until early 2014 up to 18%. And then the Affordable Care Act began, and that drove the uninsurance rate down to as low as 11%. And then once the Trump administration took office, that started to inch back up. As of late 2018, the latest numbers I have, about 14%. The Trump administration has done everything it could to get rid of the ACA. Full repeal of the ACA failed by one vote. Many of you may remember John McCain standing in the middle of the night on the Senate floor with the thumbs down for the repeal measure. He felt the process was irresponsible by not offering an alternative to the ACA. So the ACA lived to see another day, but there was substantial retrenchment. The 2017 tax cut removed the individual mandate, which is a critical piece of that reform. The Trump administration has fostered non-compliant health plans. This is a small feature of the original ACA to allow plans of 30 days or so to bridge periods which would otherwise be uninsured. The Trump administration extended that temporary time period from 30 days to 364 days. So temporary became almost annual. And also, Trump administration attempted to restrict subsidies for the near poor, although some states, including California, figured out very effective ways to circumvent that. Along with the improved levels of insurance, something less desirable happened, which is since 2014, but even from before then, we've seen an acceleration of underinsurance. This figure shows the distribution of health plan enrollment for covered workers. This is data routinely collected by the Kaiser Family Foundation. And as you can see here, where I've circled some numbers, the prevalence of high deductible health plans, that is deductibles of $1,000 or more dollars, grew from 4% in 2006 to about 20% in 2014 and to about 30% today. The size of the deductibles also grew from the same survey. We see here that in 2007, of the people with a high deductible, 14% had 1,000 or to 2,000, and 3% had 2,000 or more. As of 2018, 35% were in the 1,000 to 2,000 range, and 19% $2,000 or more. And these kinds of high deductibles, cost sharing, make a difference. Here we see that, as the title says, more than 2 of 5 adults who are underinsured report problems getting needed care because of cost. So you can see the blue bars are for people who are insured all year and are not underinsured. They have low deductibles or no deductibles and relatively low cost sharing. The darker brown bars are the uninsured, And you can see, for example, had a medical problem but did not go to a doctor or clinic because of cost. It's 44% among the uninsured. And for the underinsured, which is about 70 million people in the United States, this was 25%. So it really does matter. This is a snapshot of how we pay for healthcare in the United States. Care that is in public programs represents about 43% of spending. That's 27% federal dollars and 16% state and local. Most of that comes through the Center for Medicare and Medicaid Services, or CMS. That includes Medicare, which is a purely federal program for the aged and long-term disabled. Medicaid, which is a state-federal partnership for the poor and for long-term care. There are many other programs. We counted in California about 60 separate funding streams that are in the public domain. And that includes the state and local safety net. Care that goes through private insurers directly is about 34% of the total. Employers pay about 2/3 of the premiums for that. Families pay about 1/3. Families also pay about 12% of income out of pocket beyond premiums, and this might be a bit higher now. So another important thing that's not obvious initially, much of the private funding, private health insurance is actually paid for by local, state, and federal government agencies. So they buy private insurance for the government employees. That means that factor plus a couple of others means that in reality, 66%, 2/3 of what we spend on healthcare in the United States is public. This approach to financing healthcare causes problems with thousands of plans, poor access due to restricted networks and underinsurance, burdensome billing procedures, specifically burdensome for providers, but also for patients, and fragmented and imbalanced price negotiations according to the market position of providers and insurers, et cetera, means that we have no effective cost controls and problems with access to care. Does this matter? This graph, I think, really shows that it does matter. This shows a set of lines. Each line is for one country. This starts in 1974 and goes to 2014. And what you can see, first of all, anyone can find the United States, you get a point. Now, the United States really sticks out. Most of the countries shown here, and these are mostly from the OECD, Organization for Economic Cooperation and Development, saw a rapid rise in life expectancy from the mid-70s to the mid-2010s. This is very exciting. They also saw a growth in health expenditures. The United States saw a much lower rise in life expectancy, and in fact, since 2014, have had a couple of years with life expectancy dropping and a much bigger rise in the cost of care. So we are failing on both counts. We're doing worse than other countries in terms of this terrifically important measure of health, which is life expectancy, and we're also doing worse on costs. That's where we were, and then COVID-19 arrived and really began to highlight some of the problems we have with the healthcare system. First of all, a lot of people lost their jobs. They were laid off. The estimate, again, of the Kaiser Family Foundation is that about 27 million people were newly uninsured due to the loss of employer-sponsored insurance right here. Some people, according to Kaiser, were able to retain this insurance through either the generosity of the employers or paying COBRA payments. But basically what this means is it's about an 8% drop, an 8% increase in the percent of the population that is uninsured. Oops, went the wrong direction there. This one goes into a little bit more detail on how it is that people could potentially get insurance to replace the insurance that they lost. Some could get subsidized ACA coverage. Some might be eligible for Medicaid, but the fact that they could get that insurance doesn't mean that they do get that insurance. The other issue that came up is how to deal with the healthcare needs associated with COVID-19, and in particular, how would cost sharing be handled? Would individuals and families be liable for all or part of their COVID care, or would insurers pay for that? Typically, of course, private health plans, and especially those that offer plans with big deductibles and high cost sharing, require the payments from patients. Particularly early in the year when COVID-19 happened to arrive, these unpaid deductibles may pose major financial barriers to care. This problem was recognized, and it led to some efforts to address this for COVID-19. There were efforts, but there are buts. For testing, there is a new law that requires full coverage for the ACA compliant plans. But if you remember, one of the things the Trump administration has done is to facilitate the use of these short-term, that is 364-day non-compliant ACA plans, and an estimated 1.3 million people therefore won't get their testing paid for by those plans, and similar number in what are called shared ministries plans. So there are no doubt other categories of plans that won't pay, but there definitely are gaps. Any vaccine that's developed for COVID-19 will likely be covered once it's reviewed by a group called the U.S. Preventive Services Task Force, but typically that process can take at least a year, if not more. So new law will need to be written if the vaccine is to be covered. Meantime, it probably won't be. As for treatment of COVID-19, while the Democrats did push for a federal requirement that be covered, that was not done, but some private health insurers, that's PHI, voluntarily offered waivers of cost sharing for treatment that's COVID related. But not all of them did, and this is the really tricky part about it. How do you decide if someone's disease is COVID related? Sometimes the doctors will know. Other times the tests that are used for COVID come back negative, even though the person really has COVID disease. There's something called sensitivity, which is the ability to detect real infection, and it's about 70% for the tests for COVID. So that creates a situation where if your test confirms COVID, you may get treated. You may get your cost sharing paid for, and if not, then not. Providers also are taking a hit under COVID-19. There's a lot of disruption in the delivery of healthcare. Hospitals are estimated to be incurring about $200 billion in losses from COVID-19 care itself, from canceled elective procedures, because obviously people are not getting the elective care in this time. It's sure starting up again now, and the cost of personal protective equipment as well. Physicians are widely reported to have been having very sparsely populated practices, although somewhat compensated by the use of telemedicine, and I have not seen any particularly useful estimates of the scale of losses. Other providers as well are affected. There's another issue. Does health coverage contribute to COVID-19 control? You see here graphs of the pattern of COVID cases from 4 countries: Italy, Germany, Spain, and in the bottom right, the United States. You may notice that the other 3 curves have a peak in early April or late March, and then it drops off. In the United States, we have a much larger peak, not obvious because the scales here are different, and then it's not dropping off. So the question is, what's causing that? Well, one part of it, for sure, is mixed, ambivalent messages from the White House about what we should be doing from a public health standpoint to reduce transmission in terms of shelter in place and masks and so on. And certainly we could have done better, we could do better. But the other aspect of it is, with so many people unsure about whether they're covered, and if they're covered, whether their COVID care will be covered, a lot of people are not seeking care. They're getting sick. They're not getting assessed by doctors. They're not getting instructed to self-isolate. It's quite possibly contributing to this failure to control the pandemic. One of the countries that's done the best in the whole world is Taiwan, and there are a number of different reasons for that. But one of the reasons is that they were able to use data from their claims system, their single payer claims system, in order to get better data to help find cases and get isolation. Another issue that is particularly germane because of the Black Lives Matter increased awareness in recent weeks, COVID-19 cases in prisons have risen rapidly. There's an estimate that there are about 68,000 infected inmates. Prison deaths linked to COVID are increasing, and the 5 largest COVID clusters are in correctional facilities. So this is not a failing of our healthcare system, but just a link to that very important other social issue. What about reform? Certainly, we hear about various strategies for reform, but here I reveal my cards. I am a great believer in truly comprehensive reform. I've looked a lot at strategies used in the European countries and other countries in the OECD, and there are some consistent patterns. Everyone in those countries has exactly the same standardized health coverage. Within each country, everyone has the same coverage, and everyone is covered, and cost sharing is much less. And there's price negotiation, and billing is far, far simpler. So if we were to make tweaks to our current health insurance systems without having those fundamental elements in place of everyone having exactly the same health insurance with low cost sharing, that would mean that our system's structural flaws, that is gaps in coverage, both uninsurance and underinsurance, wasteful complexity due to all of the extra paperwork we do, and sky-high prices would continue. The public option is mentioned often as a strategy to improve the health insurance situation, but there are a couple of problems in my view. One is that there's no consistent definition of what that means. Certainly looking back to the debates, the early debates on the ACA, the definition kept shifting every few days to every few weeks. And there's no public option that I can conceive of that will fix these kinds of problems. In my view, we do need very fundamental reform. And I think the way to do that is Medicare for all or single payer. This is universal high quality coverage. Everyone is covered cradle to grave with broad benefits and free choice of providers. Elimination of financial barriers means no deductibles and low or no copays, and progressive financing. So rich people pay more, poor people pay less. Using simplicity of the billing process and price negotiation to reduce costs. That is one payment system, fair provider payments that are enough to maintain the viability of the practices, but not higher just because someone has a market share, and negotiating lower drug prices as is done in every other wealthy country. And finally, removing profiteering. The profits that the healthcare system produces have not helped solve the problem of getting people care and healthier outcomes. We did a study which was published recently looking at the cost of single payer healthcare. This, of course, is a huge issue in this area, because the question is, how can we cover everyone? If right now we're not covering, say, 10%, and some people are underinsured and therefore paying out of pocket, how can we cover everyone and not break the bank? Well, it turns out that the added cost of covering everyone are less than the savings you get by simplifying administration and negotiating drug prices. If anyone's interested, you can see the whole article in PLOS Medicine. It's public access. This is a summary. What you can see here is we found 21 studies. The red bars are the total health system cost increase due to the higher utilization because people were better covered. The green bars are the savings from simplified administration, lower drug prices, and some other factors. And the blue line, which starts above zero and then goes below zero primarily, is the net cost. So for the first few studies, the net cost initially in the first year of implementation is positive, that is, it increases cost. But according to 18 out of the 21 studies, the costs will be negative. That is, there will be net savings immediately after implementing this kind of approach, a single payer approach, and these savings will increase over time. Just to be clear, this is a total healthcare savings. The government budget or the public budget will increase. This money will all be on budget. So the government income will increase and the payment will increase, but overall the system will save money and people will pay less. A college friend of mine wrote with this sentiment, and I will end with this slide. She wrote, "It must be incredibly frustrating for you to not see single payer move forward, especially with the current pandemic and it becoming nationally evident that minorities don't have access to the same quality of healthcare and healthy living as white people." So I continue to be optimistic that people really want substantial change in our society, including, as we have seen vividly in the last few weeks, an end to racial bias and any of the vestiges of oppression, and also based on what I have observed and what I read in the polls for fundamental healthcare reform. And I hope you all stay involved in this issue and contribute in whatever way you feel is right. Thank you.
Thank you, Dr. Kahn. And we really appreciate your sharing this information with us this evening. Dr. Kahn will be here to take your questions at the end of the program, along with the rest of our panel. And I remind the audience that you can submit your questions throughout the presentations using the Q&A function at the bottom of your Zoom screen. Our hosts will be monitoring the submissions for responses to our final forum segment. And you can use your chat feature if you choose to discuss with other participants, but only the panelists will be able to see the Q&A screen. At this time, it's now my privilege to introduce our distinguished panel of 4 members of local healthcare professionals providing service right here in the Davis area in Yolo County. We're going to ask each speaker to introduce themselves and their agencies. Panel members, we would like for each of you to please tell your audience who you are and who you serve, and the unique healthcare needs and costs and access issues of those client populations, along with sources of funding for your agency. In the absence of our mental health speaker, please feel free to include relevant mental health needs of your clients. So let us begin with Brian Vaughn, Yolo County Public Health Department. Brian?
Yeah, thank you. Appreciate being invited and having an opportunity to talk to everyone tonight. So I'm Brian Vaughn. I'm the Public Health Director here in Yolo County. I oversee the Community Health Branch of the Health and Human Services Agency. We have a number of programs around prevention, maternal, child, adolescent health, communicable infectious diseases, emergency preparedness, an emergency medical system, and other programs that are under my guise. So the question, so maybe I'll start with, see if I can share my screen here. kind of what we see and what are our unique needs that we're seeing now. I think this one slide I have here kind of sums it up, the work that we do and our mission in public health. So, while we serve everyone in the county, we're particularly keen to the most vulnerable communities and populations in the county. You can see here, this is our analysis of life expectancy. And you can see there are stark differences in this county. And this is Yolo County specific. It's not necessarily unique. Although I can tell you, I've done analysis of other counties. This is one of the biggest spreads I've ever seen. 19 years in differences in life expectancy between communities in Davis and in West Sac is really large. I can tell you some of that's due to Davis and particularly how well off they are in terms of education and other indicators, and West Sac, we know of issues there. So this is what drives our work on the public health side. I know we're talking specifically about healthcare today. I both want to piggyback on what Dr. Kahn was saying, but also step back. Because I think from my perspective, at least from a public health prevention perspective, I think we talk sometimes myopically about healthcare and healthcare access in this country. And that not all of us tend to understand actually what drives good health. So I always fall back onto the analogy, that aspirin cures a headache, but lack of aspirin doesn't cause a headache. And so healthcare in that sense is the aspirin, right? So it's needed, it's necessary and sufficient to fix this slide that I'm showing you here. And yet I would argue it's not even the most important thing about this slide. So I'd like to take a few minutes just now, just talking about kind of from our perspective, from a public health perspective, how health works, because I think it's a good frame as you're going out and making choices about whether how you vote or what you support, just to know where healthcare sits in a broader spectrum of what determines people's health, particularly now in a moment when we're talking about racism and other inequities, just how important those things are. So this is a little bit of a complicated slide, but I'll walk us through it because I think it's really important as we continue to have conversations. This actually slide to me explains why our healthcare costs so much and we have such poor outcomes. So I'll walk us through it. I'm happy to take questions later, but again, I think it's really important in the context of the conversation today, just to understand how we believe on the public health side, health is driven. So this is a framework that was developed by the Bay Area Regional Health Inequities Initiative. So it's a group of Bay Area counties that have come together for more than a decade now to address health inequities. The State Department of Health adopted this framework when they put together their health equity office and plan around health and mental health inequities. And so I'll just take a moment. You can see if we start on actually the right-hand side, just how we view health from a public health perspective. So at the very end there, you have mortality, right? So dead, alive, that's the ultimate outcome of health. And we talk about life expectancy. So the next issue above that is really what we talk about is a lot of disease and injury that leads to that death, right? And so this is that $4 trillion is really talking about disease and injury and how we address it through our healthcare system. That's where the bulk of the funding goes that Dr. Kahn mentioned. And yet there's so much that goes into that, right? And so on the public health side, we move a little bit more to the left, what we would say is upstream, and we talk about the risk behaviors that lead to those diseases, right? Whether they're cancer, heart disease, we talk a lot about diet, smoking, poor nutrition. If we're more progressive, we'll talk about the role of violence and other issues that lead to disparities in those disease injuries and disease burden in certain communities. So that's all great, and that's what we talk about a lot now, but we actually, I don't think, do a great job of talking about what actually drives those risky behaviors. So I'm as guilty as anyone else in public health of going out and telling people, hey, you shouldn't smoke, you shouldn't drink, without ever addressing some of the precursors to why people may do that. I say I have 30 seconds, I'll be quick. So some of that, and I'll argue the more important things that drive that are people's living conditions, where people work, what type of education access they have, their physical environment, social inequities, or their social environment, and what kind of services are available to them, social services and otherwise. And if you go farther upstream, what drives that is health inequities or the isms that we say, racism, sexism, and other types of inequities that I'll argue, and I believe there's strong data support now, are much, much more important than having healthcare access. Again, healthcare access is necessary, but it's not sufficient to eliminate health disparities. And until we address this stuff that's upstream, that drives policy, that forces people based on the color of their skin, their gender, who they love, to live in certain places, to have limited access compared to other groups, we're not going to improve health outcomes to the extent that we want to. So healthcare plays a piece of that, and I know we're focusing on that tonight, but it's really important for me to express just how much, so much more goes into that that equation of what makes people in communities healthy. And a lot of that we just never talk about and we never address from a health perspective. And so I just want to push that forward as we have that conversation tonight, is to not forget, as we're talking about healthcare, there's all this other stuff. We could have the greatest healthcare system in the world and it still wouldn't bridge the gap on our disparities until we address all this stuff on the left-hand side of this framework here. So I'll end it there. I'm happy later to highlight how that's played out on COVID. I can tell you right now, the data we're seeing fits this mold. Unfortunately, it's the least served communities. It's the highest need, the ones in poverty that are facing now the biggest issues with COVID and COVID infections. And so I'm happy to talk about that further later in the discussion. Thanks.
Thank you so much, Brian. And now we'll move on to Dr. Melissa Marshall from CommuniCare Health Centers. Melissa, you're going to need to unmute.
There we go. Thank you so much. I'm Melissa Marshall. I'm a family physician and the previous CMO and the current CEO of CommuniCare Health Centers, which was founded in 1972 as the Davis Free Clinic. Many of you may be familiar with that. It was based on the Haight-Ashbury Free Clinic. I just want to acknowledge the comments that Dr. Kahn and Brian made, because the lens that they see healthcare is one that we share. And they've shared a very high level perspective on healthcare. And now I'm going to share how this works at the ground level, which is at CommuniCare, because we care about the same things. We are looking at the social determinants of health and everything upstream that impacts our patients. We are taking care of the most vulnerable patients that have challenges in accessing healthcare. And we are hoping to drive the system to better quality and better outcomes for our community. So I'm going to nod my head at Bob just to change the slide. Again, we started as a free clinic founded by Dr. John H. Jones, and we became a federally qualified health center in 2007. And what that means is some of our funding is federal. And I thought it was so interesting, Dr. Kahn, that you shared that 2/3 of healthcare funding right now is 66%, or is public funded. We receive a lot of public funding. We receive a federal grant. That's part of being a federally qualified health center. And we also take care of a lot of Medi-Cal patients. We also take care of a lot of the remaining uninsured. So 31% of our patient population is uninsured. And what that means is these are people that are often afraid to access healthcare because they're afraid of immigration issues, particularly in this current environment. They lack resources. They're concerned about how they're going to get transportation, childcare, how they're going to leave their work. And ultimately, we provide those services at a nominal fee, which generally is $30 for a visit, even if we pay $80 in lab work. So we do this in many different locations across Yolo County. And we provide comprehensive services. So we provide primary care, dental care, behavioral health and substance use treatment, health promotion and wellness, and support services. So we actually, when someone comes in, we try to enroll them in whatever coverage we can find for them. And sometimes this is Medi-Cal, and sometimes this is other services. Right now, we also are, we're facing a lot of issues related to COVID, because at the end of the day, we've had people who are afraid to seek care because of the shelter-in-place orders, which is understandable. And we know that dental care, as one example, has a huge rate of transmission. And so we actually closed all of our dental services to only emergency care, and then we've reopened them now. But it's a work in progress. We'll go to the next slide. So just to tell you about our patients, as I said before, 60% are Medi-Cal and 31% are uninsured. We take care of a very diverse population in Yolo County. 54% are Hispanic or Latinx, and 43% are non-Latinx. And I just want to say that, we've been doing COVID testing at CommuniCare. We've probably done close to 200 tests, which doesn't sound like a lot. But out of those 200 tests, we've had 8 positives. 7 out of the 8 are Latinx patients. So, and I know Brian could speak to this as well, but there's a huge proportion of our population right now that is Latinx, that is COVID positive. I mean, the COVID positive tests are Latinx. So we'll go to age and race. We can go to race. So we obviously take care of a large, very wide spectrum population in terms of age and race. This obviously also reflects our population. And we'll go to the next slide. So what many people may not realize is that CommuniCare takes care of 1 in 9 Yolo County residents. And that seems sort of shocking in a way because, we're actually a pretty well-off county, pretty well-off community, low rates of unemployment, and we're still taking care of 1 in 9 Yolo County residents. And what we're seeing right now is with COVID that we're seeing more unemployment. And so we're seeing more people enrolling in Medi-Cal, and we're seeing an increasing number of patients that need to access our services. And we imagine that this trend is going to continue. So, in 2019, we had 132,000 visits. We don't know what the future is going to hold. We hope that people can access coverage wherever they can and access care wherever they can. And this actually highlights a huge problem with our system, which I'll talk about later, which is this employer-based healthcare access. In other words, so many people actually access coverage through their employer. And if you don't have an employer or you're self-employed, this creates a lot of problems. So these are patient visits by type. And just wanting to highlight that CommuniCare takes care of a lot of behavioral health issues. So about 1/3 of our agency is behavioral health, and we do all of the court mandated substance use treatment for Yolo County at this time. We take care of a wide variety of behavioral health issues. We do integrated behavioral health. So if someone comes in for an appointment, they can see a clinician at the same time as they see their primary care provider. We also have specialty behavioral health. We have many, many, many programs, which I could go into if people are interested. Go to the next slide, which may be the last slide. So I think I have more to share about the challenges and opportunities that COVID presents to us as a healthcare system and as CommuniCare, and I look forward to doing that.
Thank you so much, Melissa. We appreciate hearing about your programs and the clients you serve. And moving on now, we will hear next from our panelist, Jennifer Lahai, to share her work with the Yolo County Children's Alliance.
So I always forget that I'm on mute. Thank you so much, Michelle, and thank you to the panelists. Thank you to Davis League of Women's Voters for inviting us to this forum today. One of the things that I would like to share with you is that when I shared this opportunity with my team and some of the parents that we work with, one of the parents told me, basically, thank everyone for allowing this opportunity to give voice to the voiceless. The reason why she stated that is that the main population that we work with, like Melissa shared earlier, they are underserved, they are underrepresented, and they're pretty much gone back into hiding because of the Trump administration. So when you are underserved and underrepresented, you don't feel like you are participating fully in society. You are pretty much living on the outskirts of society. So when opportunities like this come up and we reach out to our parents that we work with, they do voice their concern. They share the hardships that they're facing, especially with the pandemic. The pandemic has truly exacerbated every form of social determinants of health that low-income communities, and especially communities of color, face on a day-to-day basis. But I'll get into that later. I will definitely love to share some of the personal stories that the families shared with us. Again, my name is Jennifer Lahai. I am the Health Programs Manager for the Yolo County Children's Alliance. We were founded in 2002 as the Child Abuse Prevention Council. However, we did branch into direct services. So our programs, Bob, if you can scroll down a little bit, our programs are, Bob, can you scroll down a little? Thank you. So our programs are divided into 3 different areas: advocacy and collaboration, family support, and parent education. Last year alone, we served over 6,000 families. The particular program that I would like to focus on this evening is our Medi-Cal and Cover California health insurance navigation work that we do. We served 1,290 people last year. And I also want to focus on what we bring back to the community when it comes to economic assistance in the form of VITA, which is the free tax preparation services. In addition to that, our funding comes from federal, state, county, and as well as foundations. What we do, so the work that I do at the Family Resource Center is very much grounded in community. The Family Resource Center serves minorities from the Latinx community, African American, our Farsi speakers, as well as our Hindi speakers, Arabic speakers, Russian speakers. One of the things about the Family Resource Center, which is located in West Sacramento, it is a one-stop shop for everyone. They come to clients come to the Family Resource Center, and then we're able to triage them into different programs. The thing about Family Resource Centers, which is a statewide coalition in California, is they support the unheard, the voiceless in California. They support undocumented clients. We make sure that the staff that work at the Family Resource Center are very reflective of the community. So when a client comes in, talking about just the hardships that they're facing on a day-to-day basis, which is preventing them from connecting with either healthcare or health or their primary health provider, we are the ones who walk the family through that process. We have our community resource specialists who will then connect with the family, walk them through the process of getting them health insurance. If they don't have health insurance, then we connect them with the community care, federally qualified clinic. And then after that, we walk them through the process of how to make their doctor's appointment. After they've done doing that, we also walk them through the process of figuring out childcare to go to their doctor appointment, as well as transportation to access that appointment. So I will stop here and talk later on about how COVID has affected individual families that we work with and share some of their personal stories. Thank you.
Thank you, Geneva. And to conclude our panel introductions, we want to move now to Dr. Sheila Allen, Executive Director of Yolo County Healthy Aging Alliance, to speak with us about her constituencies.
Thank you for this opportunity. Yes, it's Yolo Healthy Aging Alliance. So we cover all of Yolo County, and we try to live up to our name. So Yolo is the whole county. We are not a county organization though. We're privately funded by donations and by grants. And then healthy aging, when we were deciding on what our name was going to be 10 years ago, we were thinking about there are other coalitions throughout California who call themselves the Senior Coalition. And it's fun. The generation right now who are growing older have a funny relationship with the word senior. So we decided that healthy aging, I don't think there's anyone on the call or on this video who would argue with the healthy aging experience. And then Alliance. We are not currently a direct service organization. We don't provide care, but we're really an alliance of bringing together voices, bringing together organizations, and bringing together people to identify and to try to work together to solve issues. So we're YOLO, Healthy Aging Alliance. It's a bit of a mouthful. And our tagline is that we endeavor to be a unified voice for older adults in Yolo County. So we do try to bring people together, and I'm very sensitive to what some of the other speakers have alluded to about the importance of being a voice for the voiceless, and we do really try to do the best that we can to bring all those additional voices to the table. So it's important that everyone is heard and that all people have a voice. So our mission is, and we're really mission driven with the activities that we have, is that we promote the well-being of older adults through these three main activities. So we have educational programs. So these are things from specific educational programs, such as education for caregivers of persons with dementia. We have a great relationship with the Alzheimer's Association. We've had Justice and Aging come in and talk about healthcare reform. So we do push out that information to all throughout the county for education. We also want to hear from the community. So we often have town hall meetings either on specific topics or more generally. So this last fall, we had a series of 4 pretty well attended town hall meetings in the 4 cities in Yolo County to hear from elected officials about what they're up to and what they're doing about older adult issues, and then hear from the community about what they think needs to happen in their community, and then to facilitate that dialogue directly from the community with the elected officials, and then give the group as a whole an opportunity to have a vision of what would healthy aging experience in their particular community be. And it was interesting that you would think, Yolo, there's the whole United States and then there's the world, but just in Yolo County, the 4 different town hall meetings we had came up with different priorities, different things that they thought were going well, and challenges. So I think it really speaks to the importance of looking locally when you're trying to see what are the needs and addressing them. Next is our collaboration committee. So this is all the different kinds of providers of services for older adults. In some of the other presentations, we were looking very specifically at healthcare, as in a clinic or in a hospital, but we look at health more broadly, and the kind of services, like we have massage therapists that are a part of our collaboration committee. We have nutrition, so we have Meals on Wheels, we have the food bank, we have the adult day health centers that provide community-based services. So all different kinds of providers, 110 different ones that we bring together so that each of them know about each other and can refer to each other. So to help to bring the what's now a very could be an uncoordinated and difficult to navigate system, so that it can be better coordinated. And then also so that we can get information to all those providers with these groups that we have together. And the third area that we work on is advocacy. And so that's really where we work on being a voice for the older adults. A great, very recent win for us is that we were working very hard with the governor's May Revise. It was very interesting that when he was first elected, he appointed a master plan for aging for California, where the older adults were a priority for him. And we were going to look at, in California, what are the services, what are the needs, how can we better coordinate it, what needs to happen. And then the May Revise comes up, and it included major cuts to adult day health was going to be eliminated, the support, the MSSP, the multi-service program for older adults was going to be eliminated, and cuts to other supports. So it was, we did a lot of advocacy, and in the end, both the legislature and the governor took those supports that helped to keep people out of the skilled nursing facilities, which is, we'll be talking about in the second part about what impact that has in relation to COVID. And I have only just a little bit, but can I go to the next slide, please? Thank you. Just want to point out for older adults that you can't really see on the slide, but that I think everybody knows that there's what's been called the silver tsunami, where right now, or in 2010, 10% of the people in Yolo County were age 65 and older, and in 2050, thank you, 22% will be. So we've gone from a pyramid society of many more younger adults and fewer older adults to more of a column where it's more distributed. So that has some real implications for healthcare and other financing. Next slide, please. And then this is, I'll be talking about this, but I just want to show you this slide now. What's really important is the second set of bars. And this shows for the person's age, the young old, as we like to call them, for persons 55 to 64, that's in Yolo County where we see the greatest level of persons below the poverty level. And we don't know for sure because we haven't asked them specifically, but one could think that what's the difference between somebody who's 64 and somebody who's 65? They have Medicare. So they have their health care is being able to take, which could take a great portion of their finances. That part, they have Medicare for all once you're 65 and older. So we'll be able to talk about that in the second part. Thank you.
Thank you so much, Sheila. We're truly fortunate to have such a wonderful panel joining us this evening. And we thank you all for the wonderful work you do to support our county and support all of these constituents within our county. We're now going to go ahead and give each of you an additional, let's say about 4 minutes or so to answer the forum question from the perspective of your constituencies. So we'll start again with Brian and then go through Melissa and then Geneva and then Sheila. And we'll ask you the forum question, what has the COVID crisis unveiled to you about healthcare access and affordability for the Yolo County populations you serve? And so we'll ask if we can begin with Brian and then
Sure.
ask you all to pick up after. Thank you.
Yeah, thanks. Appreciate the question. So unfortunately, I think what it's highlighted is it's more of the same, where early on we had a pretty wide and diverse spread of people who were getting infected. Now, our most recent data shows us that it's now the same communities that are suffering disproportionately from health disparities. So as Melissa mentioned, more than 75% of our recent cases these past 2 weeks have been what we think in the Latino community, or that's our estimate so far. There's a number of reasons for that. One of which we're finding out is just the overlay of the housing problem. So we have housing, we have people who are getting infected who are living in households with 2 or 3 families, right, who can't social distance. And as a result, they're infecting their housemates, their families that they're living with, because they can't social isolate. They don't have single rooms. And so I suspect as this progresses for the foreseeable future, we will continue to see this disparity. I looked at the state data earlier, and Latinos and Blacks suffer a disproportionate amount of the deaths now in the state. Will continue to suffer a disproportionate amount of the infections, and so much of what I talked about is overlaid on that. And a reason for it, it's not just cultural. I think we've done to be frank, a terrible job of messaging to the Latino community and other communities. The severity of this, we haven't as a county, and I would say most institutions aren't very good at reaching out to those populations in a way that we do with others. And so we have to play catch up. We're doing that now. But again, it's for me, it's not so much highlighted anything new, it's just reinforced everything we've seen. And, healthcare access will play a role in that. I think with the federal administration right now, and I know Dr. Marshall can speak more to this, just the chilling effect of people even just coming out and getting supportive services, depending on their legal status or their level of comfort in coming in, that will just compound the issue of this once in a lifetime pandemic. And we already have data around that. We're already seeing that. And I do fear with cases surging significantly that disparity will only grow. And I don't have much reason to suspect it won't. And so the people who are more well off will again be able to live without going to a job or have jobs that accommodate staying home, while it's our service workers, our essential workers and all them who are out there, continue to be out there this whole time. And now we're seeing those infections as a result of that. So unfortunately, it's not great news. I do think there's a lot more we can be doing around this. So that's to be determined, but I think right now is a time for bold action. And so I am looking forward. There's some conversations coming up, to say also, it would be remiss not to mention the things that are happening around the death of George Floyd, Black Lives Matter, how that overlays on this too. And that conversation around the role of racism and disparities, again, that I got into it in my presentation, and how we need to address that head on if we're going to get ahead of this. And so you think about how we reacted to COVID, we marshaled all these resources. And I don't think there's a reason why we shouldn't do that for racism too, and not just go back to how we were doing business before. I highlight, and Sandra may have highlighted it if she was here, that at one point we had 0 homeless in this county as a result of our COVID response. And that took all of us coming together, but that was a plan that we didn't know if we would ever achieve. And we did it within a matter of weeks because we all rallied together, we pooled resources. So I believe we can make great change. We just have to commit to it and do it differently than we've been doing it previously. And so I'm hopeful for that. But again, what I've learned is that these are falling now along the same lines that we had before, and they likely will continue to do that.
Thank you. Melissa?
Gosh, Brian, I wish we could have lunch again. So much of what Brian says resonates with me, and I just want to take a step back. Before COVID, we were facing challenges, and I'm going to get political here, but under this current administration, we were facing challenge with our immigrant population. We were facing challenges with reproductive rights. And I actually personally am a plaintiff in some litigation against the Trump administration against Title X regulations, which CommuniCare has had to forego because they basically restrict our opportunity to really provide evidence-based sexual and reproductive health education and counseling for women and families. And so we were facing challenges before in access to care and coverage and, people feeling safe. And I think, CommuniCare wants to always respond to that. I will say COVID is like, it's like what a year this week has been. And honestly, it has been incredible how we've had to respond. And I want to talk a little bit about the challenges and the opportunities because, one of the challenges is we are a migrant health center, meaning we take care of, migrant health workers, seasonal agricultural workers, and ultimately we do outreach to them. We go to the migrant camps, we do all these things, and COVID hits and we have to decide, is that essential work? Are you exposing people? I mean, we had to make decisions about, sheltering in place, all these things. And so I think, as CommuniCare and as a healthcare system, we in some ways have dropped the ball because we didn't push hard enough. And we were trying to, actually protect a lot of public health and actually abide by public health measures. But at the end of the day, it exposed what really we see all of the time, which is the fact that healthcare is a set of systems and processes, and we don't have a cohesive system. And because we don't have a cohesive system, it creates silos, it creates fragmentation, and we see this in terms of the funding for public health, which predated COVID. I mean, clearly we had basically taken away all of the foundational support for public health. And, you know, public health in some ways is the glue. It was the glue and it continues to be the glue. And we're lucky in Yolo County because we are able to work together. We're ultimately a smaller county, and we can find ways to work together and partner together and do things like Project Room Key, which was this initiative that Brian alluded to around the motels, where we, you know, the county housed all of the unhoused individuals in Yolo County in motels. And CommuniCare and other partners provided case management, behavioral health services. We provided all of the primary care for those individuals who are either at very high risk of COVID or had COVID or were suspect COVID. And so they protected the community. They also took care of this really vulnerable population. But you know, the other thing is, when you think about like Toyota, I think they had like I don't know, they had some factory that had a problem. And there was this part that they needed for all of their cars. And they rallied, they like, you know, the whole system of Toyota came together. They're like, we're gonna make the part, because everything was, you know, to make something right at the moment that you need it. And we didn't have enough PPE because we had just enough for what we usually needed. And of course, the PPE wasn't enough. So this completely sheds light on the problem of how fragmented our healthcare system is, that we couldn't work together as an entire system to get the PPE we needed, to get the testing we needed. And now we look at all of these individual, really capitalist, you know, enterprises that are trying to create this rapid testing, which actually has terrible, you know, false negatives and things like that. That's what Trump's relying on for his staff. And I will just say that at the end of the day, this highlights this issue of fragmentation. The other thing that I want to highlight is, you know, we don't do well when our coverage, our healthcare coverage, is dependent on our employer, because people get sick. You know, my husband was married to a woman who died of cancer. And when she got sick, she had to keep working so that she could keep her coverage, so that she could actually treat her cancer. Now, does that make any sense? No, it doesn't make any sense. The same thing is happening right now. The same thing is happening in terms of COVID. You know, people lose their employment and they don't have coverage, and they need coverage because there's a pandemic. So, I mean, I really do hope that this public health emergency is going to shed light on this fundamental flaw in our system and create fundamental change, as was, you know, proposed by Dr. Kahn. I mean, I think lastly, I just want to say, you know, the health disparities are real. We've seen this. I mean, we track these things in our health center. We care deeply about preventing health disparities. And we are seeing fewer people coming in for testing who are Latinx, and, you know, the higher burden of disease. And, you know, this concerns us. And I think part of this has to do with our environment, where people are afraid. They're afraid of losing their job. They're afraid of what this is going to mean for their family. So, I mean, these are real issues. But I also see opportunities, and I'm sorry if I'm talking too long. I'm really passionate about this stuff because, you know, this is what I live and breathe. I think one of the opportunities is value-based care. So we have been primarily, you know, supported financially through visits. You know, it's the widget thing. You know, it's the hamster on the wheel. We got to see more people. We got to just turn the visits. And right now, there is a question about value-based care, which includes telehealth. Can we do healthcare differently? We know the private system does this, Kaiser and other systems do this. And now we have an opportunity as, you know, a federally qualified health system to prove that there is value in providing different kinds of services that meet the need of the population and the community in a way that doesn't necessarily have to bring them into work and make them miss work and make them miss, you know, have transportation issues. The other thing is, I think this, because of the highlight on health disparities, we do have an opportunity to partner more with our partners and our colleagues to think about how we really can better address social determinants of health and how we really can look at the whole system. And I think, you know, all of the things that have happened after George Floyd's, you know, brutal murder, essentially, is that we are looking at things differently now. We're looking at what really matters and how we're going to look at the system and how we're going to contribute to making the system work better for everyone.
Thank you, Melissa. Geneva?
I echo what Brian and Melissa said. I want to take us back to 2016. YCCA, Yolo County Children's Alliance, we've been involved in health advocacy work in the county for the past several years. I can say we've been doing this work for about 12 years. So we were part of the advocacy team on the state level to advocate for SB 75, which is health insurance for all children, despite of their immigration status. That passed, fortunately in California, it passed. And we all rallied, all of the CBOs, community-based organizations that do health insurance enrollment work. We all rallied, we came up with a plan, we talked with the county and advocated, presented outreach, called families and advocated for our undocumented families to enroll their children in health insurance. At that time, prior to SB 75, Kaiser Child Health Plan was the one that was pretty much being utilized in our area. And if you were not within 50 miles of a Kaiser facility, YCCA had a plan, a children's health insurance plan that was being paid for by the tribe, Yochedehi. So we had about 50 children on that plan. We'll pay their monthly premium so they'll be able to see a doctor. So after SB 75 passed, we were so excited, but then election was happening. And then when the new president came on board, when the Trump administration came on board, we as health advocates felt so defeated because we knew that everything that we worked for over the past couple of years was going to go down the drain. So the reason why I'm stating that is, as one of my staff, who is our health programs coordinator, Jose Ceja, he submitted some personal stories that I'll read to you later on. He told me, he said, Geneva, my families, despite who the president is, anything that comes out of the White House, they take as, something that's going to happen to them 100%. They take it very seriously. So whatever the president is saying about healthcare coverage, whatever the president is saying about immigrant communities, they take that to heart. So prior to 2016, we saw our families feeling they were being humanized again in the public. DACA passed, people were being very vocal about their immigration status. They felt like they were part of the community. And then after 2016, it just felt like all the work that we've done in trying to humanize our neighbors was going down the drain. So what has happened with the community that we specifically work with, which is mostly undocumented communities, what has happened is that because of public charge, Melissa mentioned public charge earlier today, because of public charge and all the rhetorics from the current administration, most people do not feel like they are able to engage in society. They don't feel like they're part of society. So everyone is pretty much going underground. And the catch-all for the people who are needing access to care and are undocumented is our community clinic. Our Family Resource Center is constantly referring to the community clinic, which is, which also creates, I don't want to use the word a burden on resources, but it also creates a burden on resources because of everything else that's going on. So with COVID happening, you have people who are living on the outskirts of society. They are essential workers. They are the grocery workers. They are farm workers. They may have been working under the table. Some of them lost their job. Some of them, had husbands that will go out into the, they'll go out and do field work every day. Some of them did lose those positions. So now they're having to heavily rely whatever resource it is that the Family Resource Center can provide them, which is, fortunately, we're able to get some resources from the California Family Resource Center Association. We were able to provide one-time payment of $500 to a couple of families who did not qualify for the stimulus. We were able to do diapers, gas card, food vouchers. We've done so many food vouchers over the last 3 months. But before I take up too much of my time, I wanted to read you a story from one of our clients. So this is about food access, and it also ties into the social determinants of health. So CL is a new client of ours. She is currently undergoing a process for a green card petition. When clients are undergoing such processes, they are always advised to drop any public assistance programs. This is how CL was referred to us, because she was experiencing food insecurity. And to her, CalFresh was not an option, much less cash aid. CL's husband has been underemployed since the COVID-19, having had his hours cut due to low activity. Although we want her to sign up for CalFresh, we understand the conflicting information she receives from everyone, especially the news. We were able to convince her to sign up for pandemic EBT, which the state of California provided, which clearly states that she is eligible regardless of immigration status and will not be subjected to public charge. We also assisted her with food vouchers, gas cards, diapers, etc. If they continue to be underemployed in the next couple of months, they are really going to face a crisis. And a crisis could be also their housing need. So I'm just gonna leave that at that. What I would like to see moving forward, and Brian stated something that jogged my memory about reaching out to our underserved communities. I think the best way to reach out to our underserved communities is to utilize people who are of that culture and who also live in those communities. Our Family Resource Center, like I said earlier, we hire Farsi speakers, we have hire Spanish speakers who have lived in West Sac for years, grew up there, Russian speakers grew up there, lived in West Sac. So when COVID-19 happened, we were able to work with First Five in translating materials. We translated materials right away that could be utilized within our communities. We also called all of our clients. I think we made over 6,000 phone calls to the clients that we were serving in both Russian, Farsi, Spanish, to go over the guidelines from the county regarding social distancing and face covering and staying in when you're sick, all of the guidelines. But Melissa highlighted it, and Brian also highlighted this, it's very difficult to ask someone to social distance if they have to work, if they have to go out and work and then come back to a home that also houses, 3 or 4 generations of family members. I'm gonna leave that at that. Thank you.
Thank you, Janaba. Sheila?
I'm going to focus in on my population for a bit and to answer the question of what did COVID reveal about it. If you look at the Yolo County dashboard, the people who actually died were the older adults. And I think, some people are like, well, old people die. These were people who didn't need to die, or, at the time it was a matter of being infected. And what did it say about our healthcare system? I think that we've worked really hard to try to turn the corner on that, but these were our most vulnerable people. And did the people working there have the proper PPE? What did they have the proper education that they needed in order to decrease the spread of it? So those are real lives that were prematurely lost. So I think that we need to, this did reveal about about skilled nursing facilities in general. I don't think, again, if anybody on this call, raise your hand if you're looking forward to the day when you check into the skilled nursing facility. It would be no one. Not that there's not good care and there's not a reason for skilled nursing facilities, but we really have to have a healthcare system and the community supports in place so that people can stay in the community and stay connected. And that's the other thing that I think for my population that has really been revealed is about the social isolation. We've asked our older adults to stay home. We've asked everyone, but we asked them first, and we're asking them to continue, and we're asking them to probably do it longer than anybody else. So Yolo Healthy Aging Alliance started something called Phone Friends for Seniors, where we have volunteers that call up isolated older adults. And I think one of the really telling reports from our volunteers, and it's not just one time, but many times, that the older adults say, really, COVID is no different than their usual life. They're often isolated. They, this is their usual life. So I think we as a society need to have, a comeuppance about that, of how we treat our older adults and what kind of housing or what kind of services and supports that we have in place for them. So Phone Friends is not going away when COVID goes away, whenever that is. As I always say, COVID, COVID, that thing. So, I think that was, to the question of that was posed to us about what that revealed. The other thing is that healthcare has pivoted to access via technology, which is, I've had, I'm supposed to have a physical with my annual physical by phone. I was like, how's that going to, what do you think of this? And here's, that'd be interesting. But there are many people that don't have access to internet and don't have access to technology, or maybe don't know how to use it, even if they have the smartphone, even if they have a laptop. So that's another discrepancy for my population. And that's some of the focus things for the particular population that I'm working on, to speak more broadly to the question of healthcare that has been posed to us. I think we need to be careful of using the language of Medicare for all, because Medicare is not the end all beat all. It certainly is not. Many people have our Medi-Medis, they have Medi-Cal for low income persons, and Medicare, because there are donut holes and there are co-pays. And it is a very complex system. So when we are revisioning and thinking about what would make sense and what would be able to get people the care that they need that would cost less, I think we need to, maybe not just say, let's give everybody Medicare, because as somebody who works with people with Medicare all the time, that might be a good bumper sticker, but we want to have a careful thought about what that would mean. Right now, we are all sheltering in place, and it just so happens that one of my daughters happened to be in Scotland for a job for a year. And I have to say that when all this happened, is like, should she come home or what? Should she get on an airplane? But actually, we were kind of happy that she was someplace where she had full access to any of the healthcare that she would need with no copays. She's had a couple little health issues, and it was so easy for her to get the medication that she needed, to reach somebody. It just happens there. It's a part, it is a part of their culture to be able to have access to healthcare. And it is my deep hope that someday we can get our act together in the United States and think about that, because I know this is the League of Women Voters, and so we're supposed to be educating voters about thinking of who that you vote for and what kind of questions that you want to ask them before you go to the ballot box. So these are the kind of things, like what's happening now, what's government doing about it, what are people doing about it, what are we as a society doing about it. So, have a good think about that before you go into the ballot box.
Thank you so much, Sheila, and thank you all of our panelists, for helping us to better understand the challenges for our local healthcare community and the challenges at the state and national healthcare levels as well. The challenges we face and continue to face each day that relate to the pandemic, but also to our healthcare systems. And exactly as you say, to help educate our voters in our community about choices ultimately they will make that relate to the future of healthcare in our nation. We come now to the part of the forum where we are going to go ahead and entertain questions for our speakers. And I'd like to begin with a first question that comes from an audience member that asks about single payer reform. The question is directed to Dr. Kahn and asks about the prospect of possible hospital bankruptcies. What will be changing in a single payer financing system that will impact hospitals, especially those in rural areas? And then the second part of the question is, could possible hospital bankruptcies, if they aren't being paid for treatment of COVID-19, make hospitals potential allies for major reform? Dr. Kahn.
Thanks for the question. And before I answer, I'll just quickly comment that Sheila's observations about the limitations of the current Medicare program is very astute. And for that reason, often those of us who talk about single payer use the phrase improved Medicare for all. That is to cover those gaps so that Medi is a thing of the past. In terms of hospitals, and indeed, one of the advantages of a single payer system is that hospitals are globally budgeted. So they receive a certain amount each month that's based on their past costs and allowance for growth. And then if something serious happens that changes the situation, like the COVID-19 pandemic, then those annual or monthly budgets are increased accordingly. And in that way, hospitals are protected from risks of bankruptcy. We who study and advocate for single payer think that this should definitely generate support for a more stable situation for hospitals under Medicare for all. But it's a bit of a slog to get that support. Some hospitals who have strong market positions are making lots of money, profits, very high salaries, and the current system with big winners and big losers would eventually go away over a period of time. All hospitals would be given a good functioning budget, stability, certainty, etc. But the ones who are currently making a lot of money are not as excited about that as we would like them to be. The discussion is ongoing, and if anyone knows hospital directors, CEOs who are interested in understanding better what things would look like under single payer, then let me know.
Thank you. I'd like to direct our second question to Melissa Marshall. This individual says that they're wondering about services for therapy for the county's adult clients with severe mental illness or cognitive disorders. The question is, what is being done to either find and retain therapists, and has funding been cut? And then I welcome any of the other panelists to weigh in as well on mental health. Thank you.
I may need Brian's help with this one. So CommuniCare has continued to provide behavioral health and substance use treatment services even through the COVID pandemic. We've quickly pivoted to doing a lot of it through telehealth, whether that's a video visit or a telephone visit. But we're also doing in-person, triage, in-person intakes. And there's sort of this interesting distinction between what CommuniCare offers and then what the county offers. So generally for people that fall within severe mental illness, they're generally cared for by the county. And people that meet the mild to moderate distinction, they're generally cared for by CommuniCare, or if they have a substance use disorder, they're generally cared for by CommuniCare. And there are some exceptions to this, of course, and it gets, again, muddy and complicated. But for someone that needs services, they can always even just come to CommuniCare and we'll help to find them the services that they need, because that's what we do. That is the mission that we have. In terms of the funding, it's really interesting because under this new state administration, Governor Newsom, there was just tremendous amount of hope about what we could do in healthcare. And I think that, you know, he was thought of as the healthcare governor, and he was very innovative and has really kind of inspired a lot of people, brought together a lot of really interesting people across the state to really think differently about how we could fund healthcare and what programs we could do that actually could drive better outcomes and better quality for people. And some of that was through a program called CalAIM, where they were trying to basically innovate in the Medi-Cal system. And CommuniCare was involved in some of those efforts, and we were really excited about the possibilities to really truly integrate mental health and physical health and services across the spectrum. Well, COVID hit, and we just went through the May revise, and there were millions of dollars cut from the healthcare spending. And in fact, you know, the head of the Department of Healthcare Services, who came to join the governor in sort of great enthusiasm about the future, after 5 months decided to leave because really this isn't what he signed up for. So we really don't know. I serve on the Partnership Health Plan Board, which is the Medi-Cal Managed Care Board for, you know, Yolo County and other counties across California. I just was in a board meeting today. They're projecting a $70 million deficit next year for the health plan because they're having their funding cut by the state. And all of those things trickle down. So it's not independent, everything is connected. So when you talk about funding, it's very complicated. Dr. Kahn can probably speak better about this than I can. But I just know that, you know, when the health plan faces cuts, the health system faces cuts. When MHSA, which is the Mental Health Service Administration, faces cuts, it means that the county can't offer contracts to health centers like CommuniCare to provide mental health services. So, you know, we're in a really difficult time right now. And I hope that we will just be really creative and flexible and rally together, as Brian mentioned, you know, to try to do the best we can to sort of weave together this safety net of services for people so that we can, you know, take care of our population, because that's what we're here to do.
Thank
I
you.
hope that answers the question.
Thank you. Are there any other local panel members who would like to weigh in with regard to mental health, or we can move on to the next? Oh, Sheila?
Yeah, I just wanted to point out that, again, if we are taking this opportunity to reimagine what a healthcare system would look like, I think we've often done the separation of the mind and the body, so that there are carve outs for mental health. So it's a separate program, or it's a separate payer, or it's a separate number of visits as opposed to your healthcare. And I'm hoping while we're, you know, talking about reimagining, that we can imagine that your body and your mind are actually one. There's an interesting separate carve out from the carve out of mental health, and that is persons with dementia, which is, you know, again, my population that I work with, and that is not considered a mental health thing. It's considered a medical thing, but it again is similar to other kind of things that are happening in your brain, but it's carved out and paid for separately. So I'm hoping that when we're having these conversations, we can, you know, reimagine that actually your mind is a part of your body, and, you know, to have those conversations also.
Yeah, so Sheila, I think that's exactly what the governor was trying to accomplish in some of his initiatives. And I think the current financial crisis has put everything sort of
right. It's going to be a tough few years. It's going to again. Yeah.
Yes. Thank you. And thank you for helping us to understand that as well.
Maybe can I just make a quick plug too about health and mental health? And then I also think just what's always missing from the conversation is investing in prevention. So again, we're largely talking about treatment, people who have conditions that have advanced and started somewhere, and we do such a poor job of investing in prevention as a society. And so, I'll argue our health outcomes are a result of that. Other countries that invest more in a social safety net tend to have lower healthcare costs and better outcomes. It's just a piece of the puzzle that's missing. And so I always, as we talk about building up a system again, Dr. Chapman, our health officer, likes to call the healthcare system the sick care system, right? Because that's what we largely dependent on, is when we get sick. And so I just always want to emphasize that that's just not enough to have a system that cares for people when they're ill. It's necessary, but not sufficient, as I said before. we really need to rethink funding and thinking about how we fund prevention, primary prevention too. That's the real way to save money and to invest in a system and to make people healthy from the start.
Thank you. This next question is again for Dr. Kahn. Is there any analysis to determine if the increase in people using high deductible health plans was due to the requirement to have one in order to contribute to a health savings account? This individual says that that was one of the reasons that they moved to a high deductible health plan. Do you have any analysis of that?
Makes sense to me. I don't have a particular analysis. Certainly, that's one of the factors. I think another factor, the continued rise of use of high deductible plans is associated with how the ACA exchanges were set up, with the different tiers of coverage, including subsidy at the silver level, but also bronze, and one more level, I think. So I think there have been a number of factors that probably have contributed. And certainly having that savings account is particularly appealing for people who think they're in good shape in terms of their health and have higher incomes and want to use the residual at the end of the year to contribute to a retirement plan.
Thank you. Our fourth question I would put to any of the panelists, or maybe all. What's one way to help make sure that people enrolled in government and agency services don't lose continuity care due to transitions like housing or changes in their family structure? Any thoughts about that? Maybe Brian will pick your brain first.
Oh, that's a hard one.
I think what's important to remember, when we talk about single payer and things like that and these really big changes, is I always think we discount acknowledging just how broken and fragmented the current system is. And just because we know it and we're familiar with it doesn't mean it's good. And so it is a lot of COVID for me has really highlighted just how completely fragmented, even in an emergency situation. Something as simple as testing, where you see other countries have a federal response where they can test large volumes of people. And even our own labs, we just don't have a system that's set up for surveillance and public health testing at all, and the difficulties around that. So I don't know if I have an answer to keep continuity. It's just, sometimes I get disheartened of just how fragmented everything is, whether that's the mental healthcare system, physical, it's just so, it's so all over the place, and it's really hard. I understand there's so many carve-outs, there's so many specialties, there's so many different classifications. It's just, it's hard to manage and navigate people through these systems based on their benefits, and it's only getting more complex with a federal government that's actively trying to get people not on these services, right? In a way that I don't think we've seen before, whether that's through rhetoric or through actual policy. So it's not a happy picture right now of that continuity of care. I do think it does take something like a single payer system or some big change in order for us to fix it. And in some ways, I grow a little weary of trying to fix a broken system, and I don't think it's can be fixed the way it is now. I think it has to be rethought and reimagined. And I share Melissa's hopefulness we had with this governor and the plans that they had. I still hope they move forward with it. I think it was a step in the right direction. It wasn't the cure, but we need some boldness to make change here. We need to be bold, or else, it's really just what's the phrase? Putting lipstick on a pig, right? It's really it's gonna be disheartening sometimes just how fragmented it is.
I would also say, Brian, that we need to learn lessons from simple things. So, I mean, my own daughter, who had to come home because, college can't continue at college and has to come home to finish her senior year, has an HMO plan in Massachusetts and needs a COVID test. And I was really thrilled that she could sign on with OptumServe for the state testing. Her coverage, really meant nothing in California. And again, it's crossing state lines. It speaks to the fragmentation, but because the state stepped in and did the right thing to provide access for people. She got a test, and she's obviously, she's a privileged person. She's my daughter, all those things. But I mean, it just speaks to like, we have to actually see the lessons of simple things, whether it's Project Room Key, where we rallied together to house homeless individuals in our community and provided services, and the outcomes that we've seen with that, or providing testing that is open to anyone. I mean, these are lessons about what we actually need in our healthcare system and how we can make it better.
I have a less positive story to share about my son, and my son is at UCLA, was at UCLA when this all started, and got a clinical episode for which COVID-19 could not be ruled out. Very mild, but he was stuck in his dorm room for 2 weeks, and he really wanted to find out whether it was COVID-19. He wanted to get a test. And as soon as he was past the quarantine, he came right up to live at home because there was no one left at UCLA. And because he moved mid-month, no one was willing to approve a change back to his local pediatrician for 2 weeks. It didn't matter how many times he asked just to be approved to get a local test. Unbelievable.
Yep.
So what I say to that, imagine what, our underserved communities
Thanks,
face.
you, Geneva. Yep, for sure.
Absolutely.
Add that.
Well, next time I'm sending him to you.
Imagine what they face. You have someone who has the education level and the resources to advocate for themselves, and also parents who are supportive of that, versus someone who barely has enough time, has to go to work, their children are out of school, and they're having to educate their children while they figure out the work situation. It's just, there's no way we can expect people, especially when it comes to poverty, social determinants of health, and just inequality in general. No way that we can expect people to access high level of care and continue to access high level of care in that particular situation. It comes back to Maslow's hierarchy of need. What do I take care of? And that's what we're facing with, Latinx communities, African American communities. Right now, COVID doesn't really mean a lot to a lot of people. Unfortunately, that's what I'm hearing with my clients, as well as people my age. Right now, that doesn't mean a lot because there are African American being killed every day. That's more important to a lot of us than what is happening when it comes to the pandemic right now. This is an unfortunate thing, but I have to state that there's a lot more that's pressing for a lot of us than COVID-19.
In question and answer periods, you don't usually ask the audience a question, but rhetorically, I would ask the audience, is there anyone on this Zoom forum that has not experienced or known of an experience of discontinuity care in our current system? I wanted to pose a last question to each of the panel members to answer. And I remind the audience as well that we received many questions. We won't be able to get to all of them this evening, and we will be having them posted online after the forum, responses to those questions. But I wanted to ask each of you that you've provided us all with really good educational information, and having educated us, what personal action steps do you think that communities should be taking, either individually or collectively, in order to channel our connectedness to improve healthcare in our communities? And I'll take anyone to start first, but what personal action steps do you think individuals need to take moving forward to improve the state of our healthcare systems and the health of our communities?
Really simple. If you believe that we need fundamental change, say that and say it again and again. Talk to people about it. Talk to elected representatives. It's not a short-term solution, but it is the necessary long-term solution.
I would also say, as a physician, we have to follow public health measures right now, because that is what we need to do to take care of our communities and our families. And I think, you know, beyond social distancing, mask wearing, hand hygiene, and all of the rest of it, there are ways we can actually, you know, concretely take care of our communities. And I see that happening. I see people donating to the food bank, donating to Communicare, donating to the Yolo Children's Alliance, donating to Sheila's organization. I think that, you know, that generosity helps to care for our community, and that really is important right now.
Yeah, I can jump in. So I had an all staff meeting this morning, and we talked about George Floyd, and it was the first time we had a chance to connect. And we were wrestling with a lot of what can we do, some helplessness, some confusion. And one thing that I've committed myself to in the recent weeks is in public health, we have a tendency to talk about disparities as if they're this abstract concept that is just out there and look at these differences in groups. So I know I've committed myself to calling out why these disparities exist. That's not always a comfortable conversation, but it feels like now's the time that we have to be uncomfortable. And so I think something similar to what Dr. Kahn said is something as simple as just expressing it, getting it out there, saying what you're thinking. I think more than ever is just really important. And we want to be polite, but we also want to actually call out the problem instead of dancing around some of these subjects that I know can be uncomfortable amongst certain groups. But I've made a commitment to just say it like it is now and call that out because we're not going to make change if we never acknowledge or address it or own the opinions and decisions that we have. So that's something that a little step that I'm starting to take too, is just be upfront with what's happening in a way that's constructive and can lead to change.
Jennifer, do you want to go?
I was waiting for you.
Do you want the last word? I'll let you have the last word. I would like that. So I just wanted to say that I hope that we don't miss this opportunity where for a while, when all this first hit, I felt like we were all in the same boat together. And I'm a little worried now that we're all kind of going back into our own corners, literally and figuratively. And if we're going to have real societal change, I would like us to try to see, like, what are the problems and how can we come together to solve them, even if it's not, in one room, if it's via the screen or, out in a park separated from each other. But I don't want this moment, this very, very difficult moment to go by without us to have a little bit of a societal comeuppings about what just happened and how can we now come out of this better. I'm worried that because it's going to, as I've already mentioned, this is going to be some hard financial times, and I don't want the people that have the least among us to be fighting over the scraps again. That's what happened the last time. A lot of programs and things went away, but I would like us to try to work together as a community, as a state, as a county, as a city, to try to work together to kind of solve these problems going forward. That's really my optimistic look. I hope we can, because there are some big problems, but if we can bring it down, here's our first step of what we're going to do to try to deal with these big problems. Maybe we can not have wasted this big bad thing that happened. Maybe something good can come of it.
Nice.
That was very nice, Sheila.
Yeah.
So for me professionally, for us, we want to continue to make sure that the Family Resource Center is a safe space for everyone, despite their ethnicity, race, gender, whatever. We want to make sure that people who are coming to the Family Resource Center feels that this is a safe space, they can access services, and they will be seen, as well as triage into whatever it is that they need to be triaged into. Additionally, personally, I want to be a voice for the voiceless, not just with the families that I work with or our homeless individuals or, my friends that I communicate with on a daily basis. As a person of color, something that we tend to encounter, I call it you just get tired of people asking you questions. But I've had to rephrase that for myself. I just feel like it's a positive thing when someone asks questions. Some of my friends believe that if you are truly wanting to educate yourself on race and inequality and systemic racism, you should endeavor that on your own. So I have another belief that if someone is actually asking these questions, that I should allow the opportunity and share my knowledge with that person. I've had to have very uncomfortable conversations with people in the last couple of very, very uncomfortable, where it's been borderline racism. But I've committed myself to that work because I feel like as a society, we cannot grow without having those difficult conversations. And I'm also encouraging everyone on this call, if you feel the inclination to educate yourself about systemic racism, social determinants of health, poverty, inequality, everything that faces, that our society is facing, please do so. And if you are able to educate other people, your friends, your family, your social connections, social groups that you're a part of, please do so, because whatever you do in this moment is going to determine our future. We have to stand up for the voiceless. We have to be the voice for the voiceless.
We're only as strong as our weakest part of our most vulnerable part of our society.
Exactly.
Well, thank you, and I appreciate all of you for having provided those closing statements for us. I want to sort of summarize the goals of this forum. Our intent for this evening was first to inform the Davis area voters about how our national healthcare model impacts local care access, affordability, and community health and wellness in a time of COVID-19. And secondarily, also to establish a baseline foundation for what we hope to be a series of future community healthcare education forums. We could not have invited a more informative and more helpful panel than you folks this evening. And so we want to express our deep appreciation that you were able to join us tonight. We would really like to begin a voter dialogue in our community, and we would really welcome your input as well as that of our audience in terms of determining what future forums are going to be best able to inform us going forward. In closing, I'd like to say that the Davis Area League of Women Voters Healthcare Committee wishes to thank all of those in attendance for spending their time with us this evening and taking the time to learn more about these very important community health issues, and acknowledge all of the dedicated, active, informed voters that have joined us tonight, and all of our speakers and panelists this evening. We're deeply appreciative of each of you sharing your time so generously with us. We'd like to ask that everyone in attendance complete the online survey that you'll be receiving in follow-up to this evening. And as a reminder, again, the unanswered questions that we received this evening, we will make every effort to get these to our panelists in our keynote in order to get responses back for those who are asking, so that we will be posting these on the Davis League of Women Voters Facebook page for people to be able to find them. And then finally, we encourage those who may be interested in the League of Women Voters Davis area to consider membership. The Davis League is a nonpartisan, nonprofit organization, and our goal is to encourage informed and active participation in government. We're working to increase understanding, not just in healthcare policy, but also in other important voter issues, and to encourage civic engagement. We do support voter registration drives and other voter educational issue forums. Membership is open to all. If interested, please contact our membership chair, Judy Higgerson, at jhiggerson@gmail.com to learn more. So we once again thank you all for your participation, and we really appreciate the time that you've devoted to this this evening. Thank you, and good night.
All right, thank you all.
Bye.
Thank you.
Thank you.